Bismillah ar-Rahman ar-Rahim. Adjustment of ABG and ventilated COPD exacerbation. Do we adjust the pH to be close to the normal, or do we adjust the ventilator, the carbon dioxide, to be the same as the stable state before exacerbation? Which is the right? The right is the carbon dioxide. We have to calculate the stable state of the partial pressure of carbon dioxide of this patient and ventilate it on this target, not on the normal pH. The stable state of the partial pressure of carbon dioxide, and this will be associated with the stable state of bicarbonate, and the pH will be close to normal. Here the value of the arterial partial pressure of carbon dioxide depends on the carbon dioxide output multiplied by the barometric pressure minus total vapor. This is a fixed one, and this depends on the metabolic state of the patient. But the effect of the effective tidal volume multiplied by the respiratory rate, which is the minute volume, this is the main one, the main factor responsible for the determinations of the arterial partial pressure of carbon dioxide. The total tidal volume equals the anatomical disk space, which usually fixed 2.2 multiplied by the body weight, plus the alveolar disk space plus the effective tidal volume. In COPD patients, the alveolar disk space is increased on the expense of this effective tidal volume. So the effective tidal volume will gas exchange occur. This is an important one. This decrease in the effective tidal volume, so the effective minute volume will be small. That's why the partial pressure of carbon dioxide of this patient will be high. So this is an important one. The second point, if this patient developed, some sort of exacerbation, this means that the alveolar disk space will increase and the effective tidal volume will decrease. So the partial pressure of carbon dioxide will increase. This alveolar disk space will increase due to, say, pneumonia, pneumothorax, spasm, something like that. So this is leads to the decrease in the effective tidal volume, and the partial pressure of carbon dioxide will increase. So if you put this patient on the ventilator, so my target point is to come back, or is to keep in mind that I have to return the patient with his previous state of carbon dioxide after resolving the cause of the increase in the alveolar disk space, like the spasm, infection, pneumothorax, something like that. All this after resolution, so the patient will come back to this small part of the lung with this high partial pressure of carbon dioxide. So my target point is to estimate the carbon dioxide of this patient in his stable state. Again, this is the partial pressure of carbon dioxide, depends on the balance between two things. Number one, the carbon dioxide output per minute, and the effective minute volume, which is the effective tidal volume multiplied by the respiratory rate. In the normal state, the partial pressure of carbon dioxide is 40, and the carbon dioxide output is 240 ml per minute. When you come to the effective tidal volume, this is the total tidal volume minus the anatomical disk space minus 0 alveolar disk space. So the effective alveolar tidal volume is 350. That's why the partial pressure of carbon dioxide is 40. So this is the balance between these two things: the effective tidal volume multiplied by respiratory rate, effective minute volume, and this is the carbon dioxide output per minute, and this is the stable state. The partial pressure is 40. In a patient with a stable COPD, stable state, which is the balance between the central store and the peripheral store, or there is a balance between the carbon dioxide output per minute and the effective alveolar tidal volume multiplied by the respiratory rate, or in another way, the effective minute volume. Here, this is the tidal volume of this patient, and this is the anatomical dead space, and this is the alveolar dead space. Here it was 0, but this in COPD, it is here in this case is 50. I put it 50. So the partial pressure of carbon dioxide here increased from 40 to 47, and this patient is stable in this state, or on this value. This value is determined by the balance between this carbon dioxide output and the effective alveolar minute volume. If this patient develops some sort of exacerbation, this means that the alveolar dead space will increase. Say here I put it from 50 to 100. So the effective tidal volume will decrease. So this is the tidal volume, this is anatomical, and this is the alveolar dead space. So the effective tidal volume in this case will be 250 ml. So that's why the partial pressure of carbon dioxide increased from 47 to 56. When you put this patient on the ventilator, my target is two things: to solve the problem of acute exacerbation, whether a spasm, chest infection, pneumothorax, pulmonary embolism, whatever it is. And after the resolution, so the alveolar space will come back from being 100 to 50. So I have to return back with the patient to this value of carbon dioxide. So this is an important one. How can you estimate or calculate this is previous state of carbon dioxide for this patient? To calculate the stable state of partial pressure of carbon dioxide, we have to calculate what we call corrected bicarbonate. Corrected bicarbonate, which means the stable state of bicarbonate. The stable state of bicarbonate, which is the corrected bicarbonate. The formula is corrected bicarbonate equals the measured bicarbonate plus anion gap minus 12. From this is a corrected bicarbonate. How much increased? So this is increase in bicarbonate equals the corrected bicarbonate minus 24, the standard one. And we have the formula. This is formula in COPD patient in chronic state. Increase in partial pressure of carbon dioxide 1 milliliter mercury will be associated with an increase in the bicarbonate 0.035 ml equivalent per liter. See here, this is an increase in the bicarbonate will be here. So this will give me the increase in the partial pressure of carbon dioxide. So the stable state of partial pressure of carbon dioxide will be 40 plus the increase in the partial pressure of carbon dioxide, and this will be my target in ventilating the patient. This is an example of patients to how to calculate the stable state of bicarbonate and the stable state of partial pressure of carbon dioxide from this formula. This is the patient, 73 years old, COPD man, presented to the hospital with alcoholic ketoacidosis. Chemistry: sodium 136, potassium 5.1, chloride 85, pH 7.2, partial pressure of carbon dioxide 60, bicarbonate 25, VO2 75, urine ketones +2, FiO2 30%. Here, start with, this is the anion gap of this patient, sodium minus chloride plus bicarbonate. So this is 26. So the anion gap is 26. Corrected bicarbonate will be the measured bicarbonate. Here, this 25 plus the anion gap minus 12. So the corrected bicarbonate is 38. This means that the previous stable state of this patient of bicarbonate was 39. So when this 39, there's an increase in the bicarbonate in this patient was 15. So the increase was 15. We come back to the formula. Increase in the partial pressure of carbon dioxide 1 millimeter mercury will be associated with increase in the bicarbonate 0.35. So this increase in 15 will make an increase in partial pressure of carbon dioxide 43. So the previous state of the stable state of partial pressure of carbon dioxide is 40 plus 43 is equals 83. So this patient had the stable state of carbon dioxide of bicarbonate 39 and the partial pressure of carbon dioxide 83. So this is my target in ventilating this patient. If we want to be sure that these are the values, the effect of this on the pH and the effect of this pH will give you the expected pH of this case in this stable state will be 7.32. So in ventilating the patient, I have to come back with the stable state of partial pressure of carbon dioxide, this which goes with the effective tidal volume, and in this case you can wean the patient easily. Thank you.